At this time, I would like to turn today's program over to Canada Health Infoway. The floor is yours.
Welcome, everyone, and thank you for attending today's webinar. The purpose of today's national webinar is to share a detailed overview of the study's executive-level results and provide an opportunity for questions and answers. Presenting today will be myself, Colleen Rogers, and Chad Lever of our Benefits Realization Team at Canada Health Infoway. Chad is in Toronto, and I am in Halifax today. In the room with Chad in Toronto, we have Catherine Hunter and Jake Dwighty from PwC and Simon Higgins from Infoway, all who contributed to the study. I'll be providing an introduction and setting context, and Chad will speak to the details and findings of the study. Next. Just a few housekeeping notes before we get started. Your phone lines have been muted. At the end of the presentation, we'll be happy to take your questions. Throughout the presentation, if you think of a question, please write it down, and you can share your question with the person hosting the WebEx if you're attending in a group, or you can submit via the WebEx question and answer function if you're attending independently. Please indicate if your question is specifically for one of our presenters, and please type in the space for the Q&A panel and select Send to All Panelists. As we reach the question and answer part of the session, we'll direct your questions to the presenter or all presenters by repeating questions for everyone to hear. Next. The purpose of this benefits evaluation study was to examine the emerging benefits of using EMRs and complementary technologies in Canadian ambulatory care settings, to explore the impacts in ambulatory outpatient cancer care more deeply, and to provide recommendations in support of effective adoption and advanced use of EMR in these settings. Ambulatory care is a rapidly growing area with over 45 million visits in 2014. Since 2001, Infoway and its partners have made significant investments in both electronic health records and electronic medical records in both primary and specialist care. Part of this work, in partnership with hospital organizations and the provinces and territories, has included investment in 22 ambulatory care EMR implementation projects, which have impacted approximately 25,000 clinicians in 9 provinces. This study is part of an ongoing series of pan-Canadian studies and was guided by the Infoway Benefits Evaluation Framework. This is a framework that has an established methodology for evaluating national effects of digital health investments. Next. Of course, this report was a collaborative effort, and I'd like to take a moment to acknowledge PricewaterhouseCoopers consultant team, the National Advisory Panel, and Infoway Steering Committee and Working Group members, all who contributed to the development, synthesis, and completion of the study. A special thank you to our advisory panel members who provided comprehensive review and feedback on the draft and final versions of the benefits model, the study report, and the executive summary materials. We greatly appreciate the important contributions from Infoway's Ambulatory EMR Investment Project and evaluation teams for their participation in key informant interviews to validate the benefits examined in this study, and whose benefits evaluation reports greatly informed the study context and our benefits model. I'd also like to thank the Harris Decima project team that executed the 2015 Ambulatory EMR Landscape Survey. This was an important input to our study, and it provides the only current measurement of EMR adoption and maturity of use in Canada in ambulatory care. Key feedback was also provided by Cancer Care Ontario, informing the study's special focus on benefits of EMR use in ambulatory and outpatient cancer care. Next. Next. So in the presentation today, we'll be speaking to the study context and approach. We'll provide a summary of the current benefit estimates in emerging benefit areas, and we'll share key messages and recommendations that were outlined in the report. Next. So the EMR landscape study findings point to a hybrid electronic and paper environment in the majority of ambulatory clinics. In 2015, 16% of ambulatory clinics in Canada reported that their clinic maintains a nearly paperless patient record-keeping system. However, the majority, 51% of clinics, report having some electronic access to patient information, while at the same time maintaining paper charts as the main record-keeping system for patient visits. The remaining 33% of clinics report that patient information is entirely paper-based. Next. Adoption. In the study, we used routine entry of encounter notes electronically as the key measure of EMR adoption in ambulatory care. Using this measure, 31% of ambulatory clinics in Canada are using EMRs. Of these EMR-enabled clinics, 46% reported having adopted EMRs within the past 3 years, and among those, 15% adopted within the past year. This suggests that while ambulatory EMR adoption is still low in Canada, we are seeing rapid growth. Next slide. This finding is reflected in the following slide. It illustrates the accelerating growth of EMR adoption in ambulatory care settings in Canada, particularly over the last 3 years. At this point, I'm going to turn the presentation over to Chad, who will speak to the study methodology and our findings.
Thank you, Colleen. Following our established methodology, we began a review of the literature where over 200 articles were consulted to support the study, including Canadian evaluation reports and primary research studies. Literature was reviewed, focused primarily on the benefits of EMR use in hospital-based ambulatory outpatient settings, and to support a special focus of the study, additional literature was reviewed regarding benefits realized in or applicable to Canadian ambulatory cancer care settings. From these sources, initial benefit hypotheses were generated, and using defined criteria and advisory panel validation, a set of quantifiable benefits hypotheses were defined for inclusion in the economic model. Estimates from the literature were then aggregated to inform the baseline and range estimates, which were then extrapolated to the national context using Canadian source data from CIHI, StatsCan, and other relevant sources, and finally adjusted to the current estimate for the maturity of use of specific EMR functionalities associated with realizing the specific benefit from the 2015 National Landscape Survey. And that then gives us the final benefit estimate. Overall, an initial set of 20 benefit hypotheses were generated from the body of evidence reviewed, and using defined inclusion criteria for evidence to inform the quantitative model, 14 benefits hypotheses were included in the study. 8 were quantified in terms of a dollar value and 3 in terms of access to care benefits, and a qualitative summary of the current literature was done for 3 areas of emerging benefits. The full study report will be available today on the Infoway website and provides a detailed overview of the evidence and inputs for each benefit estimate, as well as a very detailed methodology and technical appendix providing all source data, associated citations, and computational approach. Some parameters and considerations with regard to assumptions and limitations of the study are important to note, that the benefit estimates are, in fact, a reflection of the research and evidence currently available, are intended to be illustrative of the current and emerging impacts of EMRs in ambulatory care, and are representative of just a segment of the full scope and scale of benefits likely being realized in any given access, quality, or productivity benefit domain. To address the potential limitations, the study team focused on benefit areas where the most evidence was available and used Canadian findings to the extent possible, supplemented by evaluation reports from Canadian implementations and key informant interviews from across the country. And where possible, gave preference to more recent, higher quality studies, included multiple sources to model inputs to minimize variation, used ranges and conservative assumptions to increase the reliability of estimates, and finally cross-referenced and validated results with multiple sources and experts from clinical and research communities. In the next few slides, I'd like to highlight the framework that guided the inclusion of evidence to support the model, provide an overview of the maturity of use estimates aligned to each benefit domain modeled in the study, and walk through a technical example. So, contributing evidence to support benefits hypotheses was assessed based on defined criterion. As indicated in this simplified table, quantification of benefit hypotheses required that all 3 classification criterion were met in order to support a robust economic benefits model. This is how we went from 20 potential hypotheses to the 8 that were quantified in the study in terms of dollar value and 3 in terms of access to care benefit, each with strong, robust evidence and quantitative results that could be used as inputs to the economic model, supporting either monetary or access valuation outputs. As I mentioned earlier, a key step in the modeling approach includes adjusting for maturity of use. For this study, we defined maturity of use as the percentage of ambulatory clinics using EMRs who could expect to be realizing a specific benefit as a result of their use of specific functionalities reported in the landscape survey. So for example, all ambulatory clinics that routinely enter clinical encounter notes, including medical history and follow-up notes electronically, are expected to realize the benefits from reduced chart pulls. This next slide illustrates the maturity of use estimates aligned to specific benefit domains modeled in the study. On the vertical axis is the percent of ambulatory clinics in Canada using the specific EMR functionality associated with the modeled benefit domain, which is on the horizontal axis. The dark yellow bar represents the percent of clinics reporting current use of the specific functionalities to support the benefit, with the light yellow representing clinics not currently using specific electronic functionalities. So, starting on the right-hand side, 15% of ambulatory clinics in Canada are expected to realize the benefit of reduced hospitalizations due to adverse drug events as a result of routine use of EMR alerts, prompts, or of a medication drug or dose interaction, as well as routinely viewing a patient's medical history, including prescriptions external to the clinic when prescribing medications. A clinic has to report using both of these functions to realize the benefit. For the next quality benefit model, 32% of clinics in Canada report EMR use as being beneficial to clinic efficiency and are therefore expected to realize the benefit of increased clinic volume and additional patient visits. Nearly half, 49% of clinics report access to important provincial or regional electronic health record assets like laboratory or drug information systems or diagnostic imaging repositories, which support the benefit areas of improved continuity of care when availability of required health information avoids unnecessary delays for patients, and in the productivity domain, reduce staff time searching for clinical information, the third in the list of chart management process benefits modeled in the study. As I mentioned earlier, 31% of clinics report routine access to clinical encounter notes and are expected to realize the value from reduced chart pulls and transcription costs. 49% report routine electronic access to lab results, as well as hospital reports and encounter summaries external to the clinic, and are expected to realize the benefit of reduced duplicate lab tests. And finally, 51% of clinics in Canada report routine electronic access to patients' DI test results, as well as hospital reports and encounter summaries external to the clinic, realizing the benefit of reduced duplicate DI tests. As you can see, there is broad variation in maturity of use across EMR functionalities and complementary technologies that support the realization of benefits modeled in the study. But now let's take the benefit of reduced hospitalizations due to adverse drug events and walk through a brief technical example of how the benefit area was modeled. So, EMR use in ambulatory care can reduce the number of adverse drug event-related emergency department visits and subsequent hospitalizations was based on two robust studies from 2010 and 2015, where results demonstrate an impact on the reduction of potentially harmful ADEs following EMR implementation, supporting electronic prescribing in an ambulatory setting at 36% with a range of 34 to 39% between the two studies. To extrapolate to the Canadian context, inputs included the number of annual ambulatory care visits in Canada, which is at 45 million, the average number of prescriptions per visit, estimated number of ADEs per prescription pre-EMR, average cost per ED visit for an ADE, rate of hospital admission for ED visits for each adverse drug event, and average cost per hospital admission for ADEs. You can consult the technical appendix of the report to access the specific values and sources for these inputs. And finally, the model would adjust for maturity of use of functionalities associated with this benefit, which included routine view of EMR alerts or prompts about a drug dose interaction, as well as a comprehensive view of medication history, which was reported by 15% of ambulatory clinics in Canada in 2015. The value of this benefit estimate was calculated by multiplying the estimated cost of an ED visit for an ADE and the rate of hospitalization following an ED visit and its associated cost by the proportion of times that it's realized given the current adoption of the two EMR functionalities. As I noted earlier, the technical appendix of the full report provides all source data, citations, and the computational approach. So, what were the study results? This study estimates $200 million in annual value related to EMR use in ambulatory care in Canada in 2015, plus 1.2 million more clinic visits thanks to expanded capacity as a result of enhanced clinic efficiency through EMR use. This overall estimate of $200 million in annual value is comprised of $95 million by reducing staff time spent on chart management processes, for example, chart pulls, clinician time searching for information, and transcription costs, which were all modeled as part of the study. $46 million by reducing the number of duplicate lab tests, $37 million by reducing the number of duplicate diagnostic imaging tests, $13 million by reducing adverse drug event-related ED visits and hospitalizations, and $4 million by reducing unnecessary delays in care through availability of required information, a benefit that accrues to patients. To summarize the report's special focus on EMR use in ambulatory cancer care, the results highlight that fewer days waiting from specialist consultation to first treatment at just over 200,000 fewer days waiting in Canada in 2015, reduced adverse drug event ED visits and subsequent hospitalizations at 3 million, and additional care realized through increased clinic capacity with 4,000 additional systemic therapy treatments and just over 15,000 additional radiation therapy treatments in 2015. In summary, only a portion of ambulatory care clinics in Canada are through their EMR adoption journey, yet there is momentum and progress demonstrated by the current adoption and use metrics supporting the $200 million in evidence-informed value. This value is illustrative of the current value of benefits being realized by Canadian clinics furthest along their digital health journey. With increased adoption, more mature use, and greater integration of multiple electronic systems and functionalities, realization of the full scope of benefits is possible. The report also outlines emerging benefit areas where the literature is highlighting value, but additional research is warranted in order to support quantitative modeling. 3 emerging benefits highlighted in the report include adherence to treatment guidelines, where EMR use supports reduced practice variation, impacting patient safety in the proportion of patients eligible to receive evidence-based care or treatment, improved scheduling, where electronic booking systems have demonstrated value by enhancing overall scheduling efficiency for patients and clinicians and minimizing the number of missed and no-show appointments. And finally, analytics, informing hospital and health system planning, having the potential to revolutionize clinical and health services research, quality improvement, preventative care, and post-acute care coordination. The study also outlines a number of critical success factors to realize value and support future implementation. Results from the landscape survey highlight that among clinics with access to electronic patient information, the overwhelming majority, 64%, manage multiple electronic systems, and on average report having to access 3 systems using 3 separate logins to support patient care from registration to discharge. Not surprisingly, barriers to realizing value reported in the survey included use of both paper and electronic charts, multiple logins, complexity of systems, and misalignment with clinical workflow or clinical needs, actual availability of equipment, lack of access permissions, and training. The survey also highlights that 57% of EMR-enabled clinics report that EMR use has in fact been beneficial or very beneficial for improving quality of care, rating 4 or 5 on a 5-point scale. When we examine responses by those in more advanced environments, we find that clinics are significantly more likely to report a positive impact on quality of care if they routinely access hospital and encounter summaries external to the clinic at 66%. This jumps to 74% if they report using 5 or more advanced functions to support patient care, and to 87% if the clinic has transitioned to a fully paperless environment. Essentially, this association highlights that until there is higher adoption, more mature use, and greater integration, the full scope of potential benefits will not be realized. So, in summary, there is evidence that the effective use of EMRs and complementary technologies can improve quality of care, patient safety, access, and productivity in ambulatory care. Clinic and clinician efficiencies account for the largest share of value measured in this study, such as chart management processes and reduced duplicate testing. But quality of care benefits are also important, and they are expected to rise over time as EMR use grows and matures. Quality of care is driven by mature use and interoperability, where the previous analysis I outlined indicates, and significant additional value is possible through addressing the most common barriers to acceleration of EMR adoption and advanced use, such as mixed paper electronic systems to support patient care, multiple logins, system design functionality gaps, misalignment with clinical requirements and workflow, and lack of available equipment. Based on the current context, summary of evidence, and the study findings, the report outlines the following recommendations to various stakeholders in Canada. 1, continue to realize the benefits of ambulatory care EMRs by investing in their adoption and maturity of use through key enabling strategies and technical solutions that meet clinical requirements. 2, accelerate regional and national measurement of EMR adoption and maturity of use in the ambulatory setting using established standards. Continue to improve the connectivity and interoperability of ambulatory EMR systems with local and provincial systems, including EHRs and e-referral solutions to support communication. And finally, address priority research areas in order to develop robust evidence on the advanced use of EMRs in ambulatory care to drive clinical value and quality outcomes of patient care and system sustainability. With that, I conclude our executive overview of the study. Thank you all for your attention, and I'd like to highlight that, again, that the full report and French and English versions of the executive summary and PowerPoint presentation are now available on the Infoway website shortly after this session, along with other communications collateral. A recording of the session will also be made available on the Infoway website in a few days, and we'll share that link out with registrants on today's session. Please, of course, visit our website for other digital health benefits, evaluation reports and resources related to the study and in other areas. Okay, I'll now turn it over to Simon Hagens, who will facilitate the Q&A portion of our session. We have time for questions. If you have questions following the session, please submit questions to the email at the bottom of this slide.
Thanks very much, Chad, and to Colleen as well, and to the PW team and all the Infoway team that worked on this study. So as Chad said, we've got some time now for questions. We've got a couple in, but I'd really encourage folks on the line to submit questions now, again, using that QA tool as part of the WebEx. So please go ahead and do that, and we will respond to as many as we can. So the first question that we have here is one that I'll direct to Catherine. We've touched upon it a little bit, but the question is asking if you can expand on how the hypotheses were deemed eligible for the quantitative modeling process.
Certainly. Thank you very much, Simon. As Chad and Colleen pointed out in their presentations, it was very much a collaborative effort that we undertook together with the Infoway team, the steering committee, and the advisory panel, and we certainly could not have gone from that group of 20 hypotheses without the support and guidance of those groups. And so we worked very closely upon firstly defining the 20 hypotheses, working together with our advisors as we looked at the methodology and went through a process where we essentially deselected using quantified studies available in the literature. We also had to make sure that those studies were indeed representative of the environment that we wanted to study. So, for example, looking at similar ambulatory care environments and cancer clinics as well. We were able to model the benefits, and as you heard, we went from 20 to 8. We were able to model benefits quantitatively using what we considered to be literature of high quality. So that did have indeed quantitative studies themselves, and we're also in like environments. Chad mentioned, and you saw reference to the areas of emerging benefits, as there were several studies that were suggested of benefits in other areas, but for which we really could not define and model benefits. But we wanted to make sure that we did include discussions of those benefits in our studies. So with the help of the steering committee and advisors, for which our team is certainly very grateful, we were able to look at studies, but also go out to our advisors and also the sites that were involved, that we studied the benefits, to also get their inputs too. And so that's how we came to land from 20 hypotheses to 8 that we were able to quantify in the study.
Great. Thank you so much, Catherine. The next question I'm going to ask Colleen to tackle, and it's about the estimates in this study. The question is, could we interpret those estimates as savings to the healthcare systems?
Yeah, hi. Thank you for that, Simon. So on that point, we were careful to represent dollars in the report as value and not as savings, primarily because the value of these benefits accrue across the system and a number of stakeholders. And for example, while there's real costs associated with things like adverse drug events and hospitalizations resulting from them that we've modeled in this study, you don't actually see in hospital and organizations a line item in their budgets for adverse events. So rather, preventing adverse events results in better health outcomes and capacity in the system to address other healthcare priorities. So it's more of a value statement that we've quantified than what I would articulate as actual cost savings, and we were careful not to represent it that way.
Excellent. Thanks so much, Colleen. So the next question I have here, I'm going to ask Chad to answer. So the question is about whether the sources differed from the 2013 study. And I think the questioner is asking about a study that was conducted in 2013 looking at benefits in community care. So, Chad, can you maybe comment upon the similarities and differences around the literature base for those two studies?
Sure. Thank you. Some of the research from the 2013 study was consulted, as there is some overlap of benefit domains between the two areas, particularly when looking at operational processes. But in the assessment of the literature, we focused on literature that was done in ambulatory outpatient settings. Now, in some cases, there was contributing literature that had review from the advisory panel and validation from working and steering group members that was, say, in an inpatient setting, for instance, but the actual process would be very applicable to an outpatient setting, and that was validated by both clinical and administrative panel members and support staff. So in many cases, the systematic review that was supporting the full suite of benefit estimates was expanded to most recent articles up to 2015, and we included those in the study appropriately.
That's great, Chad. Thanks. And just for folks that are curious, the 2013 study focused on primary care and is available on our website. So by all means, go and have a peek at it. So we have a couple of questions that relate to telemedicine and the importance of telemedicine in terms of expanding access to specialist care and whether that was part of the scope of the study. Maybe Chad, I can ask you to comment about that.
Yeah, so telemedicine resources in outpatient care, that was out of scope for the study because we weren't focused on specific clinical areas. We chose to speak to the pan-Canadian story of outpatient care across a very diverse range of outpatient services and clinical domains. And for that reason, we did not focus specifically on telemedicine resources and value that outpatient care services may have in that domain.
Chad, it's Colleen. If I may, I just want to add to that response. So obviously telemedicine is a very key support in delivering services in outpatient care settings and in enabling care outside of, the inpatient and extending specialist care to communities. In the ambulatory EMR, what we're really focused on is, the documentation and the information flow that would support those types of encounters. So, where the two intersect for me would be that ideally in the future and, as we're seeing in some instances today, that type of care delivery would be the information gathered from those types of events would be documented as you would normally document an encounter in an ambulatory EMR, and conversely, supporting that type of care, so things like images and results would be available through the record in advance of that type of consultation or care being delivered. Or for things like home care, you would have results that could be tracked in an ambulatory care record that are linked to the home care, sites and visits and therapy that's provided, so that you have more consistent sharing of information and, a better supported continuum of care for that patient. So that's how, what I would see the differentiators are between telehome care and telehealth and what we were looking at in this study.
Thanks very much, Colleen. And an important topic, and if I could just do a moment of shameless promotion of other materials available. We do have a study from 2011 that looked comprehensively at telehealth in Canada that's on our website, and a study in 2014 that looked at remote patient monitoring activities in Canada, and also COACH, Canada's Health Informatics Organization, does a biannual survey of telehealth. So there's a lot of resources out there for folks that are interested. The next question that we have, I'm going to direct over to Jake from the PwC team. The question is, was clinical reports and analytics time cost out of scope when looking at the cost of resources used to gather metrics in a paper setting?
Thanks, Simon. There was, I think, limited research available on that topic, so it wasn't something that we included in the model. As Chad had mentioned, we were trying to focus on the areas that had the most robust literature for us to rely on to include in those areas that we modeled. Great.
Thanks very much, Jake. We've got a couple of questions about the key informant interviews in terms of who was involved in those interviews, how many were there, is some of that more detailed data from those interviews available. I'll put that over to the PwC team, Catherine or Jake, if either of you is able to comment on that.
I can actually take that, Simon.
Great.
Great, thank you. There was just over 20 key informant interviews done from across the country with some members of the advisory panel, administrative and clinical members of outpatient care in health facilities across the country. Those interviews were done by the PricewaterhouseCoopers team, and that data remains, that qualitative data remains with them.
Great, thanks very much. So that was Chad that jumped in with that response. So the next question we have relates to patient experience and to what extent patient experience was included in the study. I'm going to ask Jake to weigh in this one. We did look at patient experience in some ways, but we also have some modeling relating to that with delays.
That's right. We did look at a couple of metrics of the time to treatment and the number of days that patients would be waiting ahead of treatment. So in that respect, we did include the patient experience in the model. This was another area where the research is somewhat lighter than other areas. And in general, what we were trying to do when we looked at patient experience was to give some of those, that broader context to how EMR usage is benefiting and adding value to the ambulatory setting.
Great. Thanks very much, Jake. So the next one, an excellent question that we often get, relates to outcomes. So the question is, were we able to explore any benefits or changes in outcomes of care for patients? I think there might be a couple of opinions on the table. Maybe I'll ask Chad to speak a bit to it, and then if there's folks from the PwC team or Colleen that wants to weigh in as well.
Great. I think a good example of that, thanks, Simon. I think a good example of that is in the cancer special focus. So a number of contributing studies allowed us to model that there was reduced time to treatment and additional treatments in that specific area. And while the study doesn't model specific outcomes of patients with respect to having treatment sooner, there is a good body of evidence in cancer care that sooner is better. You know, I don't think the current state of the literature, and given the breadth of various clinical areas in this space, is at the point now where clinical outcomes we were able to model. But I think as EMR adoption advances in this space, more data will be collected in order to even measure outcomes. So I think this is a space where, you know, there is some outcome measurement across a number of specialties, but through more adoption of the EMR use and quality data, that more outcomes could be tracked in the future.
Yeah, excellent, Chad. So I'm wondering, Colleen, Jake, or Catherine, this is a topic obviously we talked about a lot during the report. Either of you want to weigh in with a comment on that topic of how to measure outcomes in this space?
No, I don't have anything to add.
Well, I do recall this was an area that we spent quite a bit of time trying to see what was available and what we might be able to say about it. As Chad mentioned, we just weren't able to find the data to be able to support putting that type of analysis in here. But as he mentioned, some of our some of the metrics that we model do touch upon this. I'd also add the adverse drug events was another area that hit upon the same area, which we would expect affects clinical outcomes.
Great. Thanks.
Yeah, it's Colleen. Just to iterate what's already been mentioned, as I indicated in the earlier parts of the presentation setting context, really, we don't have high adoption yet of ambulatory EMRs, and the most rapid growth we've seen is over the last 3 years. And so for a lot of those reasons, the literature in general is immature, and it's very early days on the outcomes measurement simply because it's just, over the last few years that many of these initiatives have started to transition from actual project state to, live and program state. So it's certainly an area that would merit additional research and investigation as we continue on this journey.
Yeah, and that's great, Colleen. One more thing to add from one of our, an anecdote from one of our site visits across the country. This was a Neurology Unit, and because of the implementation of the EMR, the chair there was able to significantly advance their research capacity, and they provided me a list of the publications that they were able to generate since EMR implementation. I believe it was above 17. So it really, behoves the fact that through EMR use, they were able to recruit patients into studies, track data, and be very expeditious about medical discovery. So EMRs significantly, I think, contribute to, tracking outcomes and medical discovery, which can advance outcomes for patients as well.
Great. Okay, thanks. So a fundamental question here that I think maybe I'll point over to you, Colleen. Just clarifying the definition of ambulatory clinics as we're referring to them in this report.
Okay, yes, this is always a hot topic because certainly we have different groups out there who are defining it in different ways. In our report, we defined it in a way that was aligned with how we have actually invested in ambulatory EMR within Infoway and with our partners. And that is that ambulatory are outpatient care settings that are affiliated with a hospital. It does not include EMR, it does not include emergency rooms, and it does not include primary care clinics.
That's great. Thanks very much, Colleen. And if you don't mind, Colleen, I'm going to keep you in the hot seat for this next one as well. So we obviously talked in the report a fair bit about the importance of connectivity and interoperability. We have a question here about how will Infoway improve connectivity and interoperability of ambulatory EMR across Canada, especially considering the number of vendors and some of the standards challenges that can be encountered in this space.
So this is a great question, very insightful, because of course that is the next frontier. It's one thing to get these in place, and then the next piece is making sure that across the board they all interoperate. So there's a few things on that front. For example, at Infoway, we're still investing in certain things like single sign-on, in-context solutions for settings, including ambulatory EMR, where we're trying to, in projects, invest in solutions so that there's fewer sign-ons and that the information from other parts, other organizations and EHR assets from outside of the healthcare organization within which the EMR is functioning is receiving information that comes up in the patient context. We also have a clinical interoperability stream within Infoway that's focused on that, who are working with vendors, clinicians to identify, what is needed as far as standards and improvements across care. And there's a number of forums and discussions ongoing on that topic. And of course, things like this report point to areas where, we could do additional research or investment to help continue on that path.
Excellent. Thanks very much, Colleen. We had a couple of questions that relate to geography, specifically around how did we look at the territories, and did we look at urban and rural splits. So I'll ask Chad to tackle that one.
Great. Thanks. So the study does not report results or benefits by province. But the nice thing, or by urban-rural environment, or hospital size, or hospital, teaching or non-teaching or community. But the nice thing about the report and its, robust technical appendix is really any hospital or any region or any clinic really could use the formulas in the technical appendix and their clinic volume or patient volume in a particular area to start estimating, how that value might be applicable to them and apply their own maturity of use. So, hospitals are at very different levels of implementation, and even within that hospital, they're at different phases of implementation. So no one hospital in Canada really is at 100% implementation of EMRs and ambulatory clinics. They're all at varying stages. And I think to help us understand rural or urban or different types of hospitals or clinics, the technical report can help our stakeholders, drum up some of those estimates on the, using the report.
Great. Thanks very much, Chad. Colleen, I'm going to throw this one back over in your direction, and it's about the difference in utilization between hospital ambulatory clinics that are using an EMR that's built for ambulatory care versus hospital systems which have been extended out to the ambulatory clinics. I wonder if you can speak to that a bit, Colleen.
So anecdotally, this certainly comes up, and I can speak across our investment projects in that we've seen examples of both, where ambulatory EMRs are essentially extensions of existing inpatient hospital systems, which may have ambulatory modules or may not. And then in other cases, we have implementations where there's been a specific module for ambulatory or enterprise solution for ambulatory deployed. Now, the issue is we really, some of the earlier points, we don't have specific research now that would point in one direction of one being better than the other. What we do know is that workflow and how things are rolled out and change management are really critical to how these things end up getting used and the value that is derived from them. But, we don't really have enough evidence to point to conclusive findings as to whether one approach is better than the other from a technical perspective.
Excellent. Thanks very much, Colleen. So the next one I'm going to send over to Jake on the PwC team. Was there a focus on which clinic types were associated with higher benefits?
I would say with respect to that, it relates to the maturity of use that we looked at in extrapolating the model. So we used the Harris Decima survey and the information in that to talk about how clinics were using EMRs for different functionalities within their clinics. So the key metric there was whether they were using it for the entry of clinical encounter notes. But you'll see in the technical appendix to the report that for each of the different metrics that we modeled, there are some different maturity of use, different functionalities that we focused on for the level of benefit that a clinic would be getting for in that particular area.
And just to add to that, Jake, thanks. It's Chad. The report, as I mentioned earlier, highlights a number of priority research areas, and we really position in that section of the report, or it is positioned in that section of the report, that high-volume clinics would be a great place to start with some priority research with, areas of clinical importance and high-volume patients. That would be a great place to start to understand which clinics and operational and clinical processes would most benefit from advanced use.
Great. Thanks, Chad, Jake, for that. So we have a question here about what is the impact of the hospital HIMSS levels. So this is a tool that's used to rank hospital IT capacity. What's the influence of those levels on these results? So I'll pass that over to Chad.
Great. Thank you. Great question. So we we are aware of the HIMSS, MRAM results for Canada, and we looked at those as part of this study. They are for inpatient care, and that was, currently in Canada there hasn't been a measurement of ambulatory care use of EMRs. The National Physician Survey did survey specialists, unfortunately never was able to stratify by ambulatory outpatient practice setting. So that was the impetus for doing the 2015 Ambulatory Landscape Survey. Interestingly enough, the adoption rate that we achieved or saw from that survey is quite comparable to what we're seeing on the inpatient side for the HIMSS levels based on those on the HIMSS stages. So, it is I think, good validation and illustration that on the inpatient side, there's where that adoption level is in Canada with respect to CPOE and electronic functionalities. It's fairly similar to the outpatient side. So one might think that both are kind of going in step and proceeding in step in Canada.
Great. Thanks, Chad. Chad, I'm going to ask you to respond to this this next one as well, and that's what is the sample size for the Harris data that was shared?
Sure. Great. It's I will actually convey that the full data report from Harris Decima will be on our website today, and you'll be able to access the full report. The sample size was 285 outpatient clinics from across Canada. It's been weighted to high data to be representative of hospital type and size in every province.
Great. Thanks very much, Chad. Actually, the second part of that question I forgot to ask Chad, but the question is, could it be represented by practicing doctors? And just to note that it was a survey of actual clinics rather than necessarily the physicians in those clinics. But as Chad said, all of that data is available. So that's the set of questions that we've had. Thanks very much. Some really excellent questions and generated some good discussion here. I think we've captured all of the questions that were asked. If we haven't, or if there's additional questions that have come up, then by all means, do continue to submit questions through that email address that's up in the screen. I think I'll just turn it over now to Chad to close it out.
Great. Thank you. And thank you for all the contributors to this large piece of work and the projects that contributed their information and participation, and expert leaders from across the country and our PricewaterhouseCoopers team. With that, I thank everyone for being on the call today and wish you all a great spring.
Thank you again for joining us today. This concludes today's web conference. You may now disconnect.